Okay, hello. Thanks for joining this session. You have just seen the presentations by the ETN fellows, and now I would like to give the floor to Saskia Knies to start her discussion.
Yeah, so hello everyone. I will have a look at the presentations and I'll give feedback on all three of them. My name is Saskia Knies. I'm a senior advisor at the National Healthcare Institute in the Netherlands, the National HTA organization, and I'm a senior advisor on cost effectiveness and personalized medicine. I will first tell you something more in general on why research is important for policy organizations like the National Healthcare Institute. I think that research could help policymakers in different ways because we face all kinds of methodological problems in our daily work, and research can help answering these problems. In addition, it can also help to inform possible policy measures, so what we should do or how we should change current policy. However, I notice as both research from background and a policy advisor, the policymakers and researchers sometimes have a different way of thinking. Policymakers don't always need a very detailed calculations, but more a general view, and researchers want to do everything very precise and clear. In addition, the research results we have to be able to understand it and explain it to also other people, also to the general public. And the same holds true for the methods developed. Sometimes the methods developed are very nice and very clear for the people who developed it, and maybe also for some policymakers, but it's impossible or very hard to explain them to other people who are not that directly involved. So that's always a tricky thing. Here I just have the order of the presentations where I saw it, so I will discuss all three presentations very shortly. And I just had some questions and some policy implications on all three slides. So for the presentation of Sebastian Norman-Böhme, I saw that he looked at the domain-specific reference points for both health and income, and what effect is on well-being when reference points are not met. And I thought it was a very interesting presentation and research topic. And I just had two questions on for clarification. The first one is that the income, as I was expressed in substantial or luxury level, given by the people themselves, or by the respondents themselves, but it was not very clear to me how health was expressed and how it was measured by respondents. And at one point you stated that you also looked at the basic budget line, but for me it was not totally clear if it was the same as minimum wage in the Netherlands, or it was a different reference point for income. In addition, you have a number of policy implications of your findings. I really find it very interesting that you stated that there's a relationship between worries and well-being of people. So if people have more worries, their well-being drops. And you have different types of worries. But the problem, I think, is how to deal with this on the short and long term, because some worries you may be able to fix quite short term, but also some long-term issues could be more difficult. And related to the COVID-19 crisis, of course, then all kinds of countries within Europe are government policies in place, for example, for unemployment or small companies running out of business. This will not be in place for long term, I think. So how to deal with this? So that was my thoughts on the very interesting presentation of Sebastian Norman-Böhme. And then we'll go on to the next presentation of Sebastian Himmler. He calculated the societal, the monetary value of equality in Germany. And in that, your outcome of your empirical model, which was very interesting, was life satisfaction. But also in that case, it was not very clear to me how this was measured. And you calculated also two different quality estimates using different regression models, and there's quite a large difference. So you had OS and an instrumental variable model. And I was wondering which one will you trust more yourself? Looking at the policy implications of your findings, this new method of well-being valuation approach which you use is a new estimate or new method to estimate the threshold for willingness to pay. But you also have different methods already available. For example, willingness to pay estimates and also marginal returns of already available healthcare to estimate the threshold. Do you have any idea which method will have the influence of each method on the estimations? Because I have seen in the past that marginal returns and willingness to pay already result in different estimates of this threshold. I also know that the cost effectiveness analysis and QALYs are currently not accepted in Germany. So I was wondering if this step further of a threshold of a cost per QALY is going to be accepted. Do you think how this will be accepted by the general public? And do you think that the COVID crisis will result in more acceptance of cost effectiveness analysis or QALY estimates? And then go to the next and last presentation from Neuroscience Engaged. She looked at hospital closures and effects on cardiovascular outcomes. And you state in your presentation, in your introduction, that hospital closures could both have a negative or a positive effect on health outcomes, because maybe the most of the worst hospitals are closed, for example. But then when I looked at the analysis briefly, I only saw the negative effects included in your analysis. Is this because of your data availability, or is this because you think that the negative effect is probably larger? You also state that the length of stay in hospitals seemed to drop after hospital closure, but I was wondering if a longer length of stay at the hospital is always better. Is that an indication of better healthcare? And when you look at the policy implications, you state also that the healthcare spending in Italy is below European average. And could this be an indication of underspending in Italy? And does it mean that if you have a country which has healthcare spending above average, your conclusions are also true? And what we saw during the COVID-19 crisis, we saw that a lot of non-COVID healthcare was suspended. And can you say anything based on your conclusions, what you think that the influences of this COVID crisis will be on non-COVID healthcare? So that were my main points, and I'm really looking forward to your discussion with you.
Thanks a lot, Saskia, for this very nice presentation. You asked a couple of questions to all of the fellows. But first, before I give them the opportunity to react, I would like to give the floor to Ron Kemp, the other discussant, to start his discussion. And after that, I will let each of the EDN candidates react to the questions and remarks of both the discussants. So please, Ron Kemp, could you share your screen and start your presentation? Could you please unmute yourself, Ron?
Okay, thank you, Arthur, for the invitation to present some comments on the 3 studies of the fellows. Given my background in competition, I focus on the paper of Knies. Let me first introduce myself. I'm Kemp. I work at the Authorities of Consumers and Markets as a senior economist on the health department, and I work as the associate professor at ASAPM. So let me first start with some general ideas on how we, as a competition policy maker, use research in our work. First of all, research is very important for new concepts, new theories, and ideas. We work as a competition authority on economic issues, so theories on economic theory, new concepts are very important, and we use them regularly. An important thing for us to pick up a new theory is that it should be empirically supported, if possible. If we have some empirical support for a certain theory, we can use it, for example, also in arguments in court. There is some reluctance to use new concepts, so it can take some time before you see new theories in our work. What also is important for us, especially for lawyers, is that there are clear thresholds based on the theory. For example, we use a lot of we often use market shares, and 50% more or less implies market power of companies. So thresholds based on literature and research are very important for our work. Furthermore, we use research ourselves as well, especially to evaluate new methods and to test assumptions we made in our decisions. And also claims, for example, for merging parties should be based on research. And this brings us also to the paper of Knies, because it's a very interesting paper, and also I think we can use the ideas in our work as a competition authority. More or less, I put a framework of the idea of the ideas behind the paper of Knies. In Italy, there is cost containment. As a result, there are some hospital closures that might also result in shortage of hospital beds, and that may result in poor outcomes. But if you look at the mechanisms behind this model, more or less, I think it's important that the cost containment only works. The hospital closure has an effect on economies of scale. If hospitals close, other hospitals can become bigger, so they can reach more efficient economies of scale, and that may result in cost containment. It also may imply that there is reduced supplier induced demand. So it's especially in healthcare, supplier induced demand can be a problem. And if you have less hospitals, you can have less demand, and therefore also cost containment. And also closure of hospitals can lead to better quality, for example, which may also have some effect on the costs. So there's I think these are important mechanisms, but it is not the focus of the study. The focus of the study is the relationship between hospital closures and outcomes, healthcare outcomes. And there are several mechanisms. It can increase traveling time, and it takes some time before you get the treatment, so that can have a negative effect. Bed utilization can be influenced. It can result, I think, in shortages, so there are no hospital beds, so you have to wait for treatment. But it can also imply improved efficiency. There another mechanism can work as if patients are selecting better hospitals. That can also have an health outcome. And there is a volume outcome relationship. If you more often do a certain treatment, then the quality can be improved. Looking at the presentation and have a quick scan of the paper, I have some questions. First of all, there is a big difference between the individual and the municipality level. I'm not sure if there is an explanation, but I'm very interested to hear. You use a difference in difference approach, where I think you use the treatment hospitals, the hospitals of the municipalities where a hospital is closed, and you compare that with all other municipalities in it. Given that you have about 50 municipalities in your treatment group, you might also want to use a pattern matching approach because you have more than enough municipalities in the control group as well. I think there's a very small effect of closure on traveling. I think it was about 3 minutes. Might that be an indication that there are too many hospitals in Italy? And I'm not sure whether there are also some mergers in Italy of hospitals, and if you include them, let's see what the effect is for mergers. Furthermore, I think the treatment group has more or less a better outcomes than the hospitals in the control group. And what does this mean? Are the better hospitals closing? That can be strange from a welfare perspective. It can also have an effect on that you can see a regression to the mean. So let me explain that point with an example. So this is how you can calculate in a very simple way a difference is difference effect. And if we look at the bottom, I have an example with some numbers. So in the control group, you have a mortality of 5 persons, and in the pre-period and in the post-period, you have 4 deaths. In the treatment group of the municipalities with the closure of a hospital, you have in the pre-period 3, a mortality rate of 3, and in the post-period a mortality rate of 4. So if you do the difference analysis, the result is 2, and that implies a higher mortality. But is this a bad thing for Italy? And it becomes even bigger if you change the force into 3. So the control gets in the post-period 3, and the treatment gets in the post-period also 3. So for the treatment group, nothing is changing, and in the control group, it's an improvement of the mortality rate. And then the question is, what do we see over here? Is it an effect of the closure, or is it an effect of a trend improving the mortality rate to the benchmark, the industry benchmark? In this case, it can be 3. So is what you find really a bad thing for Italy? Also, I have some questions about causality of the hospital closures and outcomes. Is it really hospital closure, or is there a lower budget overall in Italy? And there the results may be more influenced by the budget than by the hospital closures. Another question is whether the treatment and control group are really independent. Patients from a municipality with a closure go to another municipality or another hospital, so they influence the mortality rate, for example, in that specific hospital. And also doctors will go to work in other hospitals. So are the treatment group and the control group really independent? Finally, a problem I think with endogeneity, the closure of hospitals is not random. For example, in your figure of Italy, you see that there is a cluster of treated municipalities. It's not one municipality, but it's often a group of neighboring municipalities. Furthermore, the question is, what is the effect? How does the mechanism work that you have a closure? One of the reasons can be that regions have budget deficits, and therefore they have to reform their hospital sector. But if you have better performing hospitals that are more expensive than in that region, perhaps you have more budget problems. And as a result, you get hospital closures. So is it really, is there not an endogeneity problem? Given these thoughts and questions I have, I want to stress that it's a very interesting study, very nice design and methodology. And the results I think I can use in this case, so for policy also, for which hospital to close with minimum effect. But also in our work as competition authority, I think we can use it, because often in a merger you get concentration or reallocation of certain treatments after the merger. And with this method, you can see what the effects are of such a reallocation. Also in the Netherlands, and I think in many other countries, there's a reallocation of emergency care departments of hospitals. Some hospitals will not have an emergency care department anymore. And by using this kind of studies, you can see what's, to select the hospitals with and emergency care departments with the with the least effect on the welfare quality of for the consumers, for the patients. Related to this, I think in all countries there's a discussion on the volume norms and quality. So often it's stated that a higher volume, so if you do more treatments, then the quality will improve. I think that's the studies done on this topic mainly focus on norms and quality, but do not look at where patients are coming from and whether that has an effect as well. So this study gives a new idea and a methodology how you can enrich the findings of the volume quality discussions. So thank you for this paper. It was very interesting to read, and a very good paper. I have some questions. I have one question for Sebastian Riemler. In your paper, you presented the different quality values, but for me as a policy maker, I've become a bit nervous if I see so many different values for the quality. And it depends on the specification you use, on the subgroups. What is your advice for a policymaker? Should we say, okay, different cost effectiveness per treatment per group, or should we take the average, or should we take the maximum of the results we find? So I'm puzzled with which quality value to use in studies. So that were my comments on the papers. So I think we can go back for the general discussion.
Thanks a lot, Ron, for this very well prepared presentation. There are enough questions for each of the ETN fellows to discuss. So I would now like to give them the opportunity for this. We'll be using the order of the presentations, which means that Sebastian Neumann-Böhme will now start with his response.
Thank you, Arthur, and thank you, Saskia, for the nice discussion and your good questions about the paper. So your first question was how we expressed health, and I have to apologize. We had to really cut down the presentation in terms of size, so I wasn't really able to explain everything. So that was a very good point. We measured health as expressed in the with the EQ5D 5L, and then summarized that to a score and called it a health problem index. And the higher you score, the more health problems you would have. And then the second one, the basic budget line, no, that wasn't the minimum wage. And this is recorded, so I'm not going to try to say it in Dutch because that would be very embarrassing. There is from the Social and Cultural Planning Office, there is a publication called Mapping Poverty. And they have 2 lines for the Netherlands. It's the basic needs budget line, so it's sort of a minimum budget that you would need to live in the Netherlands in terms of housing, shopping, and so on. And then there's a second budget, which is only slightly higher. That's called a not much but adequate budget. So we took this basic needs budget basically as an external point for like, yeah, as an external reference point in there. And maybe one last thing that Arthur sort of mentioned in his introduction that might be interesting in this well-being discussion overall was we used as a scale for well-being the Diener Subjective Well-being with Life scale. And as Arthur pointed out, when we presented it at some conferences, we got feedback from other researchers saying, well, this is a very interesting scale, but 2 of those points, the last 2 questions, are quite age-specific because they ask, so far I've gotten everything important in my life that I want, and if I could redo my life, I would change almost nothing, which is, well, if you're like at a certain age, you can probably answer those questions quite well. But for younger people, like for 18-year-olds or even younger, these questions are probably harder to answer. So that was a very interesting one. In our paper, we tried it out as a sensitivity check. It didn't change anything, but I thought in a general discussion about well-being, this might be an interesting aspect as an instrument that we use.
All right, thanks, Sebastian, for addressing the questions. And now I would like to go to the other Sebastian Himmler, to give his answers.
Yeah, thank you for the questions. Well, so Saskia, you also mentioned the question on like how we measured life satisfaction, and this is pretty much a standardized question that is included in many panel data sets across European countries. And it's basically just asking like, how satisfied are you with your life, all things considered, on a 0 to 10 scale, from completely dissatisfied to completely satisfied. And this is basically what is used in this well-being evaluation literature most of the time. And sometimes there are also like versions where it's like 0 to 6 or 7 scale, but that's basically it. Yeah, I mean, your point, like your Saskia, and also Ron's point was, well, we have a lot of different estimates. For once, we have like different estimates for like ordinary least squares regression, but also then for instrumental variable regression. And Saskia, you asked which of the ones I kind of trust more, and well, I would say that I would trust the IV estimates more, but as IV estimation in itself is often viewed flawed, or some people are not big fans of IV estimation in general. Many economists try not to use it because it has some assumptions in it that are difficult to prove. That is why we also kind of presented both sets of estimates in the end. So that, well, to be very transparent. And I would say the IV estimates are the ones that are closer to reality, and I would trust those more. And relating to Ron's point, which also is like kind of the main contribution of the analysis that we made was, well, we know that this sort of method exists. We have applied it before in a different paper where we also look at the monetary value of a year in full well-being. But with this very big data set that we used here, we were able to address a lot of different issues, a lot of issues that have not addressed been before in this type of literature. Therefore, we wanted to show with like this big data set, which allowed us to test a lot of things, the impact certain assumptions have on such estimates. So the endpoint of this study was not really to have like one estimate for Germany or have like, let's say 2 or 3 estimates or like a range of estimates that we think should be applied in the German context. The point of the paper was to say, okay, well, if we use this kind of approach for estimating a monetary value of QALYs or similar measures, well, what should we consider, or what does certain specification, or what do certain specification mean for the results in the end? So this is why we still present like a lot of different results, and I hope that in like some follow-up studies, we will be able to, or other researchers also will be able to use like what we found in our study to their advantage, and then kind of create like more precise or narrowed down estimates for contexts which are then in the end more policy relevant than our estimates. I think one of the other questions that were phrased were, yeah, the relationship of this approach and the corresponding estimates and like the other estimates that are already out there. I mean, yeah, it is true that there's like willingness to pay approaches with like a lot of different publications that have like also quite varying estimate sizes of the monetary value of a QALY, as well as the estimates on like the opportunity cost side. So that's kind of the two main methods that have been used before. Well, it's difficult to say how to relate to them, because conceptually the values that we produce are different and also encompass other things than, or less things than maybe some other willingness to pay approaches do. And in terms of, well, I do not think that any of these 3 methods will be able to really pin down the actual value that the society attaches to a monetary, to a QALY, or the actual opportunity cost. I mean, everything will just be like an approximation. So basically, we just show this question from a different angle, and we're like having different angles at the same kind of subject. We hope that we can kind of narrow down the range of such a value. And I mean, in the Dutch policy context, they do use a range of ISA thresholds from 20 to 80,000 based on severity, but it's also it's an adaptive threshold. So there will never be like one value or one very narrow kind of band for informing policy. Although I do agree that for policymakers it would be easier to have like this is the value and then take this for your actually decisions. I think the last 2 questions that were asked, I think I can combine it because, well, it was about, okay, cost effectiveness analysis is currently not used in Germany, and then relating question to it. So what's the point of this exercise for Germany? Well, as I said, our main aim was to develop insights for other researchers in other contexts as well, and point out like the pitfalls or the important things to consider while using this approach. And at the same time, I, as a health economist from Germany, I still hope that Germany may want to move in that direction at some point. And while there doesn't seem to be like, don't seem to be many politicians that want to go that way, I hope that by creating like evidence or creating some research around the topic, maybe this will become more important in the future. And relating to the last question, whether COVID-19 kind of may increase the acceptance of cost effectiveness analysis or similar analysis in Germany or in general, I would also say yes. I guess that people are now more aware of the trade-offs that politicians have to be made, and the trade-offs that have to be made every single day, the trade-offs, the uncomfortable trade-offs between health and like economic consequences of such a pandemic. And therefore, I think that it is kind of a chance for health economists or for researchers in this area in general, that people and politicians are now more aware that these kinds of tools can support their decision making and make it more transparent in the long run, and hopefully also more effective and efficient in the long run. Yeah, but these were my responses. So back to you, Arthur.
Yes, thank you, Sebastian, for your clear answers. Then I will go to the final speaker, to Nirosha, to respond to her questions. Please go ahead.
Thank you, Saskia and Ron, for your feedback. I'll try to answer some of the questions. So one question was regarding the data availability. So given the literature, we hypothesized that the effects of hospital closure could be either positive or negative. And what we find is negative effects of hospital closure. And regarding the data availability, we are limited by the fact that we only have in-hospital mortality. So we only sample those patients who are admitted and not those who died on the way. So this could affect our results in some way, but nevertheless, this kind of gives us a lower bound estimate of the effect. Another question was regarding the length of stay. So the longer length of stay need not necessarily be better, because in our study we kind of so what we find is hospital closure increases the length of stay for patients, and we interpret this as increased severity of heart attacks. So patients cannot reach to hospital on time, so their situation becomes worse, and thus they need more time to recover, so higher length of stay. Regarding the policy relevant question, so one question was, will these conclusions be relevant for countries that spend more? And this could may or may not be true. So one, if a country spends more, then there are less chances of hospital closure, and given our findings, this means better patient outcomes. And another reasoning is that even if a country spends more, but if they have some hospitals that are underperforming or underutilized, but the health system in the country is not good enough, for example, to make sure that the remaining hospitals cannot respond well to the sudden increase in demand, or they cannot kind of set up some temporary emergency services near a hospital that closes, then this could be bad for patients. So I think the keyword here is selective closures, or making sure that the health system can very fastly adapt to this hospital closure. So it really depends. Another question was regarding the COVID-19 crisis and how this would affect the non-COVID healthcare. So what we see from literature is that during the 2008 recession, the largest number of, so it was during the 2008 recession when the largest number of hospitals closed down. So we could kind of assume a similar scenario here. And if so, then this could really affect non-COVID healthcare, such as AMI outcomes or delivery, maternal delivery cases. And on top of this, we also have the situation where we have a shortage of beds because many hospitals are converted to COVID hospitals, making the situation worse. However, it should also be noted that during this pandemic period, there is more funding from the EU to invest in healthcare compared to the 2008 recession. So we really don't know what's going to happen. Moving on to Ron's questions. One question was regarding the big difference in the estimates at the individual and the municipality level. So I think the difference is coming from the fact that our specification is more robust or correct at the municipality level, because our some of the definitions, for example, a definition of being treated is explained at the municipality level. So a municipality is said to be treated if at least one home hospital in a municipality closed down, and an individual is said to be affected if that person belongs to that municipality. So if a patient is living at some part of the municipality and may not necessarily be affected by a closure, in our study, we consider that patient to be affected. So at the individual level, the specification is not so on point, which could result in this variation. Regarding the pattern matching approach, we did consider this at some point, and it's definitely another option. Another point was on the very small effect of closure on traveling time. And something to be noted is that in our data set, we cannot compute the exact traveling time between the location of residence to the location of the hospital. So what we compute here is a municipality to municipality. So center of a municipality of residence to center of the municipality of hospital travel time. So this has two implications. One, if a patient from a municipality M gets admitted to a hospital which is in the same municipality, then the travel time is considered 0. And if a patient in municipality M gets admitted to a hospital in municipality M1, then all the patients in that municipality M has the same travel time, despite whichever exact location they live in that municipality. So this kind of underestimates the effect of closure on traveling time. Definitely in Italy, we have a lot of hospitals, and most of them are like very small hospitals. And we also include mergers in our data set. Regarding treatment group having overall better outcomes, I think this is mainly because of the fact that we don't have out of hospital mortality. In a study, 2016 study on hospital closures in Sweden, I think the author, he finds that in hospital mortality is somewhat, looking at the descriptive, is somewhat higher in control groups. And lower in treated groups, whereas out of hospital mortality is always higher in treated groups. So probably this is a data availability problem. Regarding some other concerns regarding endogeneity and so on, something that I noted down was if the treated and the control groups are really independent. I think one way to go to solve this would be like consider 3 groups, one which is a control group, one is a treated group, and one is a group known as the inflow group, where there is some crossover between patients. This is already implemented in another paper by Daniel Abdick, so that could be one option. So I guess that's it. Thank you.
Okay, thank you, Nirosha. Now we are already more than 10 minutes running out of time, so I will skip the panel discussion. I hope you have enjoyed this session. I think it was very interesting, and I would like to thank all of the session members for your contributions. With this, I would like to end the session. Thanks for your attention.